Morning, everybody. So, today we will discuss some of the aspects of what are the transfusion strategies and coagulation correction strategies in variceal bleeding in cirrhosis patients. This will be the outline. So, these are the transfusion blood products that can be transfused: RBC, FFP, platelets, tranexamic acid. These are the agents which can be used, and we'll see if they are required and in which circumstances they might be required. So this was the initial 1980s studies in rat models. Uh, this model was portal vein stenosis model, and in which 15 milligram per kilogram body weight of blood, that is 20% of the calculated blood volume, was withdrawal and then reinfused. So as we can see, if you look at the change in the pressure, this was the period when hemorrhage was done, then stabilization, and then blood reinfusion. So if you look at this line, reinfusion of 6 ml per kg, that is 40% of the initial blood volume, then what happens is this dashed line is portal pressure and this line is the blood pressure. So at 40% of the blood volume reinfusion, portal pressure has almost returned to normal and arterial pressure is somewhat lower than the normal. But as we infuse 80% of the initial blood volume, arterial pressure has returned to the normal, but the portal pressure has increased about 11% from the baseline. And when 100% of the blood volume has been reinfused, then the portal pressure at the end of blood restitution is almost 20% higher above the baseline. So that was the concept of about half of the blood volume should be replaced rather than full volume. Now in the same portal vein stenosis model were divided into the three groups: severe hemorrhage, moderate hemorrhage, and control. So severe hemorrhage was 25% of the calculated blood volume let down, moderate hemorrhage was 20% of the calculated blood volume let down, and control was no hemorrhage, only portal vein stenosis. So we can see as compared to the controls, at the end of blood reinfusion, what is happening? Portal vein pressure has increased from 17 to 19. Portal venous inflow is almost the same, but portal collateral resistance has increased. So portal pressure increase above the baseline is due to the increase in the portal collateral resistance rather than portal flow, because we know portal vein pressure is flow into resistance. Now this was another study on CCL4 model of cirrhosis, and which showed that portal pressure increase above the baseline was correlated with the degree of portal systemic shunting. So two models were developed: high portal systemic shunting, in which after 10 weeks of CCL4, surgery for portal vein constriction was also done, and in low portal systemic shunting there was no surgery, only CCL4 infusion was done. Again 20% of the calculated blood volume was withdrawal at the rate of 0.3 ml per minute, and then after 15 minutes it was reinfused. So this showed that the percentage of portal systemic shunting in low portal systemic shunt group was 4.5%, and in high 78% shunting fraction was there. So if you look at the human analog, human alcoholic cirrhosis is a high portal systemic shunting, about 80% portal systemic shunting has been shown, whereas in the viral hepatitis it is a low portal systemic shunting group. So what happened here? So after the blood infusion, in the low portal systemic shunting group, the portal pressure remained almost the same, but in high portal systemic shunting group, the portal pressure increased after restitution. Now, why is this happening? So, again in the same study, it was shown that portocollateral resistance in the low portal systemic shunt group almost the same, but in the high portal systemic resistance group there was a change in the portocollateral resistance, whereas the portal venous inflow did not change. So again the third model was there in CBD ligation mouse. In this, after 6 weeks of CBD ligation, 10 ml blood was let down and 3 groups of reinfusion were made. In first group, there was no transfusion given. In the second group, 50% of the expected blood loss, that is 5 ml was given, and in the third group, almost 100% of the expected blood loss, that is all the 10 ml were reinfused. And as can be seen, in rats where 100% reinfusion was given, 10 ml group, none survived. When no transfusion was given, still 50% survived, and when half of the transfusion was given, then 64% survived. So full transfusion is detrimental in bleeding. So what could be the factors that contribute to worsening of portal hypertensive variceal bleed? So in variceal bleeding, hypotension occurs, we do resuscitation, increases portal collateral resistance, portal venous pressure increases, blood goes into the gut, there are neuroendocrine stimulus, then there is reflex splanchnic hyperemia and increased splanchnic portal flow and blood flow. This is the main component, this is maybe a smaller component of there, and over transfusion is one of the factors that leads to increase in portal pressure. So over transfusion has to be avoided. It is better to keep blood pressure on the lower side rather than higher side. So this was the initial clinical studies in which showed, this was the first study which showed the low hematocrit target, that is 25%, is preferable to high hematocrit target in cirrhosis with severe acute variceal bleed. In this 90 cirrhotic patient with severe bleed was defined as hematocrit less than 27%, and they were randomized to group 1 where transfusion target hematocrit was 25% and group 2 with having target of 32%. In this study no vasoactive drugs were given and follow up to 6 days, and it as was expected. So rebleeding rates similar in the both the groups, mortality similar in the both the groups, whereas as expected number of RBC transfused was more in the high target group. So hematocrit target of 25% is preferable as compared to higher targets. Now this was the NEJM study which showed that restrictive blood transfusion was better than the liberal strategy in cirrhosis with acute variceal bleed. This was a study from Barcelona. Adult patients with hematemesis, melena or both, 461 randomized to restrictive strategy and 462 liberal strategy. In this trial, HB levels were measured after admission and again every 8 hours during the first 2 days and then daily thereafter. And 1 unit packed RBC was transfused initially, and then HB was assessed after transfusion and further units were transfused if hemoglobin was below the threshold, and thresholds were restrictive strategy group, threshold for transfusion was 7 gram per deciliter and the HB target post transfusion was 7 to 9. In the liberal strategy group, HB threshold for transfusion was 9 gram per deciliter and post transfusion HB target was 9 to 11. But important is that these group of patients were excluded. Massive bleeding were excluded, acute coronary syndrome, symptomatic peripheral vasculopathy, stroke, TIA, these were excluded because they might need higher hemoglobin levels. So what was found that in restrictive and the liberal strategy, child C were about 20% in both the groups. Esophageal varices is the most common cause of bleeding, gastric and peptic ulcers the next. It was found that restrictive blood transfusion led to less further bleeding as compared to the liberal strategy. For example, Further bleeding was overall in patients with cirrhosis, it was higher with liberal strategy. CTP A or B also higher with liberal strategy, whereas in the C, although there was a trend, but it did not reach significance, maybe due to the small number of CTP-C patients. And bleeding from esophageal varices was also better controlled with restrictive strategy rather than liberal strategy. And the effect of mortality was also shown, which showed that restrictive blood transfusion improved 6 weeks survival versus liberal strategy. Child PUG A and B, there was clear-cut beneficial effect, whereas in child C, the effect could not be shown. In patient with cirrhosis overall, there was a beneficial effect on mortality. So why this is happening? Because liberal blood transfusion increases HVPG versus restrictive strategy in cirrhosis. And as can be seen in restrictive strategy, HVPG was similar, baseline 20, and again after 2 to 3 days it remained the same, whereas in the liberal strategy it increased significantly from 20.6 to 21.4. But we have to individualize transfusion strategies in some specific situations, because many groups have been excluded from all these trials. So patients who are bleeding massively and with marked hypotension, who continue to bleed, in such cases hemoglobin value early in the course of acute bleeding are actually minimally decreased, and substantial intravascular volume depletion overestimates the true hemoglobin levels, and after fluid resuscitation only the hemoglobin comes down. So it may be reasonable to transfuse such patients even above the before hemoglobin threshold of 7 gram per deciliter reaches. And patients who have comorbidities that make the continuation of anemia dangerous for their underlying condition, for example ischemic heart disease, cerebrovascular insufficiency, advanced age, meaning more than 70 or 80 years. So in such cases it may be reasonable to transfuse when hemoglobin falls to 8 rather than wait for 7, or when cardiovascular symptoms develop in hemodynamically stable patients with pre-existing cardiovascular diseases. Now, in some cases preemptive tips may be indicated. This is what generally consensus on. Patients with CTP-C or CTP-B with active bleeding on endoscopy or HVPG more than 20. They are candidates for preemptive tips, and in such cases 20% acute cardiac failure may occur in preemptive tips. So we do not know what should be the transfusion strategy in such cases. So this is what Bavino 7 recommendations for packed RBC transfusions in acute variceal bleed. So perform packed RBC transfusions conservatively. Target hemoglobin between 7 to 8. In individual patients, consider other factors like cardiovascular diseases, age, hemodynamic status, and continuing bleed. Now what about FFP transfusions? So this was a multicenter USA retrospective study on 244 patients with cirrhosis and acute variceal hemorrhage, and 41% received FFP. So as can be seen, patients who received FFP had advanced cirrhosis, and patients with advanced cirrhosis are more likely to get FFP. Patients who received FFP had higher CTP scores, CTP-C percentage was more, MELD was higher, they had more ascites, and obviously their coagulation were more deranged as compared to patients who did not receive FFP. Again, in the same study it was shown that patients who had active, severe and high risk bleed, they were more likely to get FFP. Patients who received FFP were more actively bleeding at the time of endoscopy. They had lower blood pressure, they had lower hemoglobin, and time to endoscopy was earlier in such cases because they continued to bleed and were severely bleeding. Rescue tips was more, and they were high risk variceal bleed, that is CTP-C or MELD more than 19 in higher percentage of patients who received FFP as compared to those who did not receive FFP. And again, it was found that FFP transfusion in acute variceal bleed is independently associated with poor clinical outcomes. So mortality at 42 days among patients who received FFP was 9 times more among those who did not receive FFP. Failure to control bleeding was 4 times more, and length of stay more than 7 days was twice as likely in patients who received FFP. So the independent association of FFP transfusion with mortality at 42 days persisted when the cohort was restricted to only high risk patients and in patients even without active bleeding. So FFP transfusion is detrimental. Now Bovino 7 recommends that variceal bleeding is due to portal hypertension. So aim should be rather lowering portal pressure rather than correcting the coagulation abnormalities. So FFP is not recommended. It will not correct coagulopathy. It will lead to volume overload and worsening of portal hypertension. But still FFP continues to be given. Why? Because when packed RBC is transfused, clinicians are inclined to transfuse balanced amounts of FFP and platelets as per the general major bleeding protocols, which say that after 3 or 4 units of RBC, you should transfuse 1 FFP and 1 platelet. And second reason is that advanced cirrhosis frequently have a prolongation is in PT-INR, and there is an inclination to correct that in a patient who has bled. Because as we see in the previous study we had discussed, about 19% of the patient who received FFP had INR less than equal to 1.5. So they were technically not coagulopathic. So in these patients, FFP was given not to improve their coagulation, but as a response to RBC transfusion. But we have to understand that in patients who are bleeding, thrombin generation is normal. As can be seen in this study from UK, there were 14 cirrhotic acute variceal bleed patients and 74 non-bleeding cirrhotic patients. And as expected, cirrhosis with bleeding had lower hemoglobin, lower platelet count and prolonged PT interval. But time to peak thrombin generation was actually lower in cirrhotic acute variceal bleed as compared to non-bleeding cirrhotics. Peak thrombin generation was higher. Endogenous thrombin potential was also higher. So that means that there is no deficiency in thrombin generation and coagulation mechanism. And procoagulant factors are upregulated and anticoagulant proteins are downregulated, including protein C, S and antithrombin. So let's see what about platelet transfusions. So this was a study from AIMS which showed that this was a retrospective study on 913 cirrhosis patients with acute variceal bleed. They divided patients into 3 groups: platelet less than 20, between 20 to 50 and more than 50. Child C patients were more in with platelets less than 20 as compared to the other groups, and as expected platelet transfusions were given in more number of patients who had platelets less than 20 or 20 to 50 as compared to more than 50. But in all the 3 groups, rebleed at 5 days, rebleed at 42 days and death at 42 days were similar. So that means that thrombocytopenia per se has no effect on rebleeding rates or mortality in cirrhosis patients with acute variceal bleed. And in the same study it was shown that patients who received platelets had actually higher rebleeding rates as compared to the patients who did not receive platelet transfusions. At day 5 rebleeding rates 14.6% versus 4.5%, and day 42 rebleeding rates 32.6 versus 15.7, whereas the mortality remained the same. So this is what Bovino 7 recommends. In acute variceal bleed, platelet counts and fibrinogen levels are not at all correlated with risk of failure to control bleeding or rebleeding. So in cases of failure to control bleeding, decision to correct hemostatic abnormality should be considered on case-to-case basis rather than any particular levels. Now, if we decide that we have to correct, then viscoelastic tests based correction is better than the PT-INR or platelet based, that is conventional coagulation test. This was a RCT from AIIMS, New Delhi. 60 patients with cirrhosis with acute variceal bleed, platelet less than 50 and or INR more than 1. They were divided 30 into TEG based blood transfusion and 30 conventional coagulation based. These were the thresholds for TEG based transfusion. FFP were given when R time was more than 15 and platelets were transfused when maximum amplitude was less than 30. Now it was found that total amount of FFP and platelet transfused was more in conventional coagulation group, this is expected, as compared to the TEG group. Patients who were transfused based on viscoelastic test, TEG based, had less rebleeding at 42 days, as can be seen. Day 42 rebleeding rate is 10% in TEG based, whereas 36.7% in the conventional coagulation test, and there was also differences in the mortality in the two groups. So what about lastly tranexamic acid? There is a laboratory evidence of hyperfibrinolysis in the blood in cirrhotic patients, especially child PUC B and C. In this study, systemic hyperfibrinolysis was defined as FDP more than 10 and D-dimer more than 200 nanogram per ml, and in CTP-A none of the patients had systemic fibrinolysis, in CTP-B 26% and in CTP-C 75% had fibrinolysis. But symptomatic hyperfibrinolysis is rare, that is they do not actually bleed spontaneously. And acute variceal bleed can further lead to hyperfibrinolysis in cirrhotic patients. This was a South Korean study, 70 cirrhosis patients with acute variceal bleed and 15 non-bleeding cirrhosis groups, and it can be seen in the bleeding group D-dimer was significantly higher and fibrinogen degradation products were significantly higher. So patients with child B and C have evidence of systemic hyperfibrinolysis, which can further get aggravated during acute variceal bleed. Now, why is this important? Because plasminogen activator is released due to increased cell degradation in the ulcers. So, if plasminogen activators are released, then it converts plasminogen to plasmin, and then fibrin is degraded to fibrin degradation products. So free plasmin enters may cause bleeding or delay healing when venous bleed permeates the ulcer area, and fibrinolytic activity of the epithelial surfaces of the submucosal blood vessels, they interfere with ulcer healing and they increase the bleeding risk. Now if we look at the pathophysiology of post-EVL ulcer formation, this is the what happens histologically. So after EVL, initially there is a polyp-like appearance and where the base is compressed by the band. Then in the next 2 days, ischemic necrosis of the polyp with superficial mucosal epithelial sloughing occurs from 0 to 2 days, and followed by coagulating necrosis in the submucosal vessels. So there is no thrombosis from initial 0 to 2 days, and after that 2 situations can happen. If band remains in C2, variceal thrombosis is seen by day 2, and by day 3 or 7 band slip off, esophageal ulcers develop and ulcers heal in 2 to 3 weeks. If band slip early, sometimes it occurs, then the dilated submucosal vascular channels are exposed to the fibrinolytic activity, and then necrosis of these channels occur before mature thrombosis form, and bleeding for the ulcer site occurs. So early bleeding can occur if band size slip early, whereas if bands remain in situ, then delayed ulcer bleeding can occur. Local fibrinolytic activity can increase the risk of necrosis of dilated submucosal vascular channels. They interfere with hemostasis, they delay healing and increase bleeding risk from ulcers. And advanced cirrhosis has been shown to be a risk factor for post-EVL ulcer bleed. In many studies has been shown. This is one of the studies, and from South Korea, 430 cirrhotics undergoing EVL, 7.7% post-EVL ulcer bleeding, And on multivariate analysis, we can see MELD score more than 10, concomitant gastric varices, and detachment of early ring bands were risk factors for post-EVL ulcer bleed. So this was a study that was done from ILBS. Shanton did this study. Tranexamic acid, there have been many studies in acute variceal bleed. There have been 4 meta-analyses which have been inclusive from 2020, 14, 21 and 22. But problem was that only 2.5% to 16.1% of the patient with cirrhosis in these meta-analyses. Then came the HALT IT trial in 2020. In this, 45% with cirrhosis, and 5-day mortality was 5.5% in the Trenexa and placebo groups. Of CTP B and C among cirrhosis are not reported, and mortality may not be a good endpoint for patients with bleeding cirrhosis, because ultimately if they rebleed, they can be tackled by salvage techniques, intervention radiology or other techniques, it can be salvaged. So this was the study that was done from ILBS. The inclusion criteria were CTP B or C, which had higher risk of rebleeding due to post-EVL ulcer, age more than 18, and patient presenting with upper GI bleed within 24 hours from onset. And these were the exclusion criteria. Clinical evidence of DIC, CKD, recent CVA, seizures, thrombotic events, and HCC were included, which had thrombosis. So this was the regimen that was used. Loading dose of 1 gram added to 100 ml sodium chloride, 0.9%, and infused over 10 minutes. And then maintenance dose of 3 gram added to 1000 ml of saline or any isotonic solution and infused at 150 mg per hour. What we found was that there were 300 patients in each group, tranexamic acid 300 and placebo infusion 300. So in this, failure to control bleeding by day 5 was significantly less in tranexamic acid group as compared to the placebo group, and esophageal EVL site as the source of failure to control bleeding in 4.9% versus 12%. Day 5 till 6 weeks, the results were similar. Esophageal EVL site was source of bleeding in 8.5% as compared to 16.4%. The mortality benefit was not seen, because patients who rebled, they could be salvaged by intervention radiology techniques. So preemptive tips has been advocated, and there is a consensus on that. Preemptive tips within 72 hours, ideal duration is less than 24 hours. From esophageal varices and type 1 or 2 GOV who have CTP-C less than 14 points, CTP-B with active bleeding and endoscopy, or HVPG more than 20. But uptake of preemptive tips is actually very low. In our study, it was found that almost 60% of patients in either group were eligible for preemptive tips, but what was ultimately about 2.3% or 1.6% of the patients could undergo preemptive tips, and reasons was cost, there is a lack of insurance cover, and patients' non-willingness when actually the bleed has stopped after the first endoscopy. So to summarize, ladies and gentlemen, and tranexamic acid could be especially beneficial in such cases, because if we look, if all the patients who were eligible for preemptive tips would have undergone preemptive tips, probably the results would have been different. Summarize, in most patients with acute variceal bleed, conservative packed RBC transfusions target hemoglobin between 7 to 8. No need for FFP or platelet transfusion. In case of failure to control bleeding, decision to correct abnormality should be considered on case-to-case basis. And if we decide to correct coagulation, then viscoelastic test based correction is preferable, and tranexamic acid in CTP B and C should be used. Thank you very much.